Hello, and welcome to this PrecisCa mini tumor board on breast cancer. My name is Dr. Reshma Matani. I'm a breast medical oncologist at the University of Miami Sylvester Cancer Center, where I co-lead our breast cancer program. It's my pleasure today to be joined by several well-renowned experts in breast cancer, who I'll now ask to introduce themselves. I'll start with Dr. Shah.
Hello, I'm Chirag Shah. I serve as the Director of Breast Radiation Oncology at the Cleveland Clinic.
Hi, I'm Stephen Poplack. I'm a breast radiologist, professor of radiology at Stanford University.
Hi, I'm Monica Morrow. I'm the Chief of Breast Surgery at Memorial Sloan Kettering Cancer Center.
Hi there, I'm Dr. Sarah Hurvitz, Professor of Medicine at the David Geffen School of Medicine at UCLA, where I'm a medical oncologist specializing in breast cancer.
This is a 38-year-old premenopausal woman with stage 4 triple positive invasive ductal carcinoma of the right breast, initially treated with neoadjuvant chemo, surgery, and adjuvant hormonal and biologic therapy that was interrupted due to the development of cardiotoxicity. She developed bone metastases requiring palliative radiation, reinitiation of HER2-directed therapy, which again had to be stopped because of cardiotoxicity. She was then transitioned to oral chemo and a tyrosine kinase inhibitor with improvement of metastatic disease and resolution of the cardiomyopathy. And we're asked to comment on the continuation of the current therapy, or would we add trastuzumab now that the ejection fraction has improved? So originally this patient presented with a palpable mass in her right breast, eventually developed pain, erythema, and ulceration. She had a good performance status, no medical issues, G4, P3, no toxic habits, and had a maternal aunt who at an unknown age had breast cancer. As stated in 2016, she was diagnosed with the locally advanced triple positive tumor that was treated with gaserelin, doxorubicin, cyclophosphamide, and then a taxane, trastuzumab, pertuzumab. And then at the time of mastectomy had residual disease. And this was, of course, before the era of the adjuvant use of TDM1. So she went on to receive pertuzumab and trastuzumab in the adjuvant setting, and despite her considerable risk of local recurrence, she declined adjuvant radiation. And during the time that she was receiving adjuvant HER2-directed therapy, she sustained a drop in the EF to 45%. The pre-treatment baseline was 65%, and on this basis, the HER2 therapy was discontinued. She did have staging scans with no evidence of distant disease, and after some initial delay because of decline, because it was declined by the patient, she eventually did go on tamoxifen, but then unfortunately was lost to follow-up. And 2 years later, after being off tamoxifen for a few months, unfortunately was found to have bone involvement in multiple areas, as well as a palpable right axillary mass biopsy, which was biopsied and confirmed, again, the same markers, triple positive breast cancer. She had to undergo a kyphoplasty, and at that time also had a vertebral body biopsy that again confirmed metastatic triple positive disease. After undergoing palliative spinal radiation, a repeat echo was done, the EF normalized, and on this basis, she was rechallenged with dual antibody therapy and along with hormonal therapy in the first line, which is an interesting choice. I think we can discuss that. And at the time of initial assessment for response, she had improvement in the bone and axillary lymph node disease. The EF was 45% at this point again, and on this basis, the trastuzumab and pertuzumab was held. A month later, the EF worsened, she became symptomatic, and the decision was made to continue hormonal therapy alone. Then in December of 2020, the EF worsened yet again to 35%. And PET scan at this point showed progression of disease. Unfortunately, this patient was then lost to follow-up due to many psychosocial barriers. And after being off letrozole for several months in March of this year, represented with worsening disease found by PET with new involvement in the thoracic spine. And on the basis of the tucatinib, capecitabine, trastuzumab regimen from HER2-CLIMB, the decision was made to use 2 out of the 3 treatments in that triplet, again, holding trastuzumab given the underlying cardiomyopathy. And here on tucatinib and capecitabine, patient did have improvement in the right axillary lymph nodes, which we'll see on the next slide, and improvement in the lesion at C2, and then the echo did normalize. Before I move on, Dr. Poplack, do you want to add anything to the PET images that are shown here that are pretty easy to see the improvement at C2?
Sure, we can just see slices at the level of the cervical spine, upper cervical spine. You can see an area of avidity in the posterior elements on the right on the April scan, which diminishes, still some avidity, but diminished in the July scan. You want to show the next? And this is just the level of the axilla, where you can see in April the increased PET avidity in the right axilla, which resolves in the July scan.
So the question we're being asked is regarding reinitiation of trastuzumab, and I'll just say that, you know, as with real life cases, as opposed to engineered cases that we sometimes see at educational programs, this one is a bit complex. Again, just to quickly summarize, this is a young woman, 38, presented with locally advanced triple positive breast cancer, 2016, had AC followed by THP, neoadjuvant, had residual disease, declined radiation in the adjuvant setting, couldn't get through the year of HER2-directed therapy due to cardiotoxicity, had delayed initiation of tamoxifen in the adjuvant setting, was lost to follow-up for 2 years, presented in 2020 with lymph node and bone disease, received palliative radiation for bone pain, a short attempt at reinitiation of HP and hormonal therapy, again had a drop in the EF, and is now responding well to tucatinib and capecitabine. So Dr. Hurvitz, would you approach this case as sort of, if it's not broke, don't fix it? She's on tucatinib and capecitabine, leave her alone, or given the efficacy results, including a survival benefit we saw with the HER2-CLIMB regimen, would you be really motivated to keep re-challenging this patient with trastuzumab?
Yes, unfortunately, this patient developed a known toxicity from HER2-targeted therapy that is significantly augmented by her history of use of anthracycline-based therapy. Nowadays, I like to hope, I think that most of us have omitted the use of standard anthracyclines from the treatment in the curative setting and are opting for a taxane-based approach without anthracyclines based on comparative trials such as TRAIN2, Chinese trial that has looked at TCH versus ACTH type regimen, and TRYPHAENA, as well as the BCIRG-006 study, none of which showing an advantage with an anthracycline-based approach, but significantly increased toxicities in terms of cardiac toxicity as this patient experienced, which is a long-term side effect. So in this particular situation, I like to make sure I've involved my cardiology colleagues and that the patient has been optimized with ACE inhibitors, with cardiac imaging, advanced cardiac imaging, and working very closely with cardio-oncologists has often allowed me to be able to continue treating the systemic metastatic disease in an optimal way. For a patient like this, I would leave well enough alone here and continue the tucatinib-based therapy with capecitabine, omitting the trastuzumab. And the reason is this: we know she will, a patient like this will experience disease progression, and we are going to want to be using trastuzumab-based approaches, things like trastuzumab deruxtecan, which has stunning efficacy results. And so what I'd like to recommend in a situation like this is that we take the opportunity to really optimize the cardiac health of a patient like this, so that we have the ability to use very effective therapies going forward.
with the hope that she can take advantage of some of those in the future for sure. So it's interesting to see that at age 38 with no other comorbid cardiac conditions like hypertension, high cholesterol, the only issue was the use of anthracycline in the past that she developed cardiotoxicity, which I think, again, as you point out, really highlights our need to be very, very selective in who we're exposing to anthracyclines. So Dr. Morrow, at the time of the, this seems like more of a systemic therapy discussion, but I'll just ask you if you have any comments from the surgical perspective in terms of her initial management or at present. And Dr. Shah, the same question for you.
Well, I think the big issue about patients with metastatic disease is whether or not there's any benefit to surgery. This is primarily in people who present as stage 4 disease. And I think that after 3 different randomized trials, one from India, one from Turkey, and one the ECOG trial in this country led by Seema Khan, that we have a much more clear picture that, number one, in the vast majority of patients whose metastatic disease is controlled, their local disease is controlled at the same time, so you don't need to operate on them. And it doesn't look like surgery in the setting of primary metastatic disease offers anything in terms of improved survival. And I think perhaps the most noteworthy thing out of the ECOG trial was that although local disease progression or local problems were about twice as frequent in the no surgery arm, there was no difference in quality of life between the 2 arms. So I think in people who have metastatic disease, whether it's de novo metastatic disease or in the setting of local regional recurrence as well, that surgery should really be reserved for palliation of symptoms that are not controlled in other ways, because most of the time it necessitates stopping their systemic therapy, which is really the mainstay of their treatment.
Thank you. And Dr. Shah, any comments on this case?
Yeah, I mean, the only comment I would make is she obviously presented with very advanced T4N3 disease and underwent surgery. And, you know, obviously she declined radiation, which is obviously a patient's choice. I think the one thing that's coming out of some of the modern radiation trials, which we didn't always think about before, is we've seen a couple trials show in more node positive patients that the addition of radiation, particularly to the lymph nodes, seems to have some impact on the rate of distant metastatic disease, and that controlling local regional failures may impact distant disease. So I think that's something that's kind of been emerging from modern data. So even in the setting of modern systemic therapies and surgeries, radiation therapy still can have an impact on local control and distant disease.
Okay, thank you all for your input on this case.